I would like to present to you the results of our use of endoscopic foraminoplasty in the treatment of adult spondylolytic spondylolisthesis over the last 20 plus years. The study covers patients with Marding slippage grades 1 to 3, suffering with the combinations of back, buttock and leg pain, and in whom 12 months of physiotherapy and pain management had failed. Patients were stratified by their grade and the presence or absence of failed fusion surgery, patients with interpars fusion, and those in whom the adjacent level was causal were excluded from the study. In each case, the procedure commenced with foraminal diagnostic probing to confirm the source of the presenting symptoms, and was then followed by transforaminal endoscopic lumbar decompression and foraminoplasty. As slippage develops, the superior foraminal ligament and fracture stump impinge on the exiting nerve root, and the lateral recess distorts the track of the descending nerve. Treatment starts with the removal of the superior foraminal ligament and then the stump and widening of the lateral recess. This removes impingement and restores freedom of movement for both the exiting and descending nerve roots. The disc is seldom the source of any pain. Where there is a concurrent focal protrusion, then this needs to be treated with endoscopic discectomy in the same procedure. The objective of the procedure is to mobilize the often tethered nerve roots and remove impingement and irritation whilst preserving intervertebral movement and limiting stress rises in the adjacent segments. We routinely and prospectively review patients at 6 weeks, 3 months, and 2 years with questionnaires and face-to-face consultations. During COVID, we retrospectively reviewed patients from 1998 onwards using our database emails, family doctors, NHS IDs to present the questionnaires and then conduct face-to-face or remote reviews. Where a response was not forthcoming, we sought responses from treating clinicians, or in the case of patients' death, from discussion with relatives. The focus of the study was to assess the improved functionality achieved with this technique and its survivability, the incidence of complications and the presence that the posturally induced painful but treatable condition of cuneal nerve trigger point irritation might be making on outcomes. The study surveyed 226 patients, of whom 127 had already been treated with posterolateral or PLIF fusion. They'd suffered symptoms for 2 to 12 years. Their ages ranged from 26 to 74, with a mean follow-up of some 15 years. At 2 years, 1 patient was untraceable and 8 more were lost to retrospective review. 38 were reviewed face-to-face, 94 remotely, and the remainder by questionnaire or discussion with the patient's family doctor, relative, or spinal or pain management clinician. Our assessment used the combination of low target levels of pain measured on the visual analog pain scale, low disability measured on the Oswestry Disability Index, and workability levels or return to retirement activities as measured on the Prolo scale. Well, at first this graph may look a little daunting. I've tried to collate the functional outcomes in the non-surgery group by slippage grade, separated by the black lines. As expected, there is a modest deterioration in functionality, with patients slipping from excellent to good and good to fair. Interestingly, a couple of patients who had been poor migrated upwards to fair. Early on, 2 patients deemed worse, following the intervention, went on to have benefit from fusion surgery. Overall functionality was excellent or good in 93% of patients at 2 years, and the benefit was maintained at 83% of patients in the long-term review. Now we should examine the failed fusion surgery group. The graph is laid out exactly the same. Not surprisingly, in cases of failed back surgery with greater levels of scarring or distortion by the intervertebral implant insertion, we did not achieve such high numbers in the excellent group. Most of the patients fell into the good category. Again, there is slippage from excellent to good and from good to fair. 1 patient improved from poor to fair over the period. 1 patient in the poor group went on to have a revision of the fusion procedure, but without benefit. At the 2-year review, 91% of the group were excellent or good. This was sustained at 86% at the long-term review. Looking at general evaluations, as may be expected, the majority of lyses were present at L5S1. They were more common in men than women, although the incidence seems to be getting less as time passes on and ladies become involved in more strenuous sports and activities. And right-sided symptoms seem to be the commonest. Endler et al. In 2019 found adjacent segment deterioration in 26 to 42% of 131 posterior fusion patients at follow-up, on average 11 years after surgery. It was not clear how many of these segments were symptomatic. In our patients, some recorded new and different symptoms at the long-term review. These were modest and were reproduced by displacement of the adjacent segment rather than the target level. Complications were rare: 1 superficial wound infection, 1 discitis, and 1 small dural tear. Cuneal nerve trigger point irritation was noted at the long-term follow-up to be contributing to persisting symptoms in 12 to 23% of cases. This condition can be readily treated by physiotherapy, steroid injections, and radiofrequency ablation with lasting benefit, which should further improve our current outcomes. So the technique starts with confirming that the lytic level is indeed the source of the pain. In our earlier study, in 20% of cases, the adjacent level was causal. This is a salutary lesson to be aware that lysis may in fact be the innocent party. The need for fusion is minimized, but not prejudiced by endoscopic foraminoplasty. Endoscopic foraminoplasty with 83 to 86% excellent or good long-term functionality outcomes compares favorably with the fusion surgery outcomes where, for instance, Ekman et al. In 2005 reported 76% of fused patients classified their outcome as much better or better, an average of 9 years later. Detection of cuneal nerve trigger point irritation offers the potential to further uplift the outcome results following endoscopic foraminoplasty. An endoscopic foraminoplasty offers, I would suggest, a commendable physiological solution for the treatment of spondylolytic spondylolisthesis. Please consider endoscopic foraminoplasty when you think of fusing your next spondylolisthesis patient. Thank you.